So the topic I will be talking is a little bit different from what I just heard in the lecture before. It was something about taking breath and being calm, you know, things like that. The topic I will be talking today is the problem that we have a lot of ineffective treatment in healthcare, and we have a waste of healthcare resources, at least in Germany. And I think nurses can help us to avoid ineffective treatment and to avoid the waste of healthcare services. So the definition of health economics is more health for less medicine. You understand economics. Economics is nothing about money. Economics means to compare what you have to give away and compare it with what you get back on the other side. So you see, when you go to the market and you see very nice pineapples, and they would cost 3 reais, or how much is a pineapple? 3 reais. You see a nice pineapple for 3 reais, and on the other side you see even a nicer pineapple for 4 reais. Then you are doing an economic analysis, because you compare the nice pineapple for 3 reais with the even more nice pineapple for 4 reais. And then you try to make a decision and to ask yourself, should I spend 3 reais or 4 reais? Is it worth to spend 4 reais for this better pineapple? And this is a complete economic analysis. And what I want you to do is to use this form of an economic analysis in your day-to-day nursing practice. The basic idea of a novel concept of nursing is, it may be interesting only to some nurses and to some doctors, not to everybody. The focus of this novel concept is patient outcome. You know, we especially we doctors, we don't care too much about outcomes. We are very much interested in doing diagnosis. We are interested in doing treatments, but you know, outcomes, we don't have too much time for outcomes. So nurses and doctors should have a common goal, and to provide the best possible health for the least resources. And nurses and doctors can, and they should, make different contributions to healthcare. And the different contributions are easy to explain. Nurses and doctors have different attitudes. You understand attitude? Ways of thinking. Do you agree with that doctors and nurses have different attitudes? Nurses and doctors have different skills. This means abilities, what they can do. And nurses and doctors have different knowledge. Nurses know a lot what doctors do not know. And doctors have some knowledge what nurses do not know. So, the idea is, let's bring them together and make something in common. So doctors care about screening. Do you understand what screening is? Screening, breast cancer screening, colorectal screening, so you know this, or screening for pediatric disease.
Radiografia, ok. Escaneamento, ok. Screening.
Okay, it's clear. So doctors care about screening. They are very much interested in diagnosis, and they are interested in treatment. Nurses are much closer to patients, and nurses care about patients. Their focus is the patient, not screening, diagnosis, and treatment. You see, doctors are a little bit more theoretical. Nurses are more practical. And the experience of the last decade told us that we need this practical side. So doctors are interested to introduce new tools or new methods in order to improve screening, diagnosis, and treatment. Nurses, it's completely different. Nurses are interested in the overall outcome. So what happens at the end of the story with the patient? And they are interested in quality of life, in patient's quality of life. And this has tremendous consequences. So we may generate better outcomes if we combine these attitudes, skills, and knowledge of doctors and nurses. Doctors usually provide excellent technical service. Doctors often don't have attitude, skills, and knowledge for communication. Is it the same in Brazil? In Germany, doctors don't talk too much. And this is something what patients complain about, that the doctor does not have time, he is not interested to talk to the patients. And this is a big problem in Germany. Patients feel that doctors lack time for communication. Novel nursing can contribute at two levels, at two different levels, to improve the value of healthcare, as communication is an essential need to guarantee two things. First, the most efficient healthcare, and second, the best assessment of outcomes. And this is a point I want to address in the next couple of slides, the best assessment of outcomes.
Pessoal, entenderam alguma pergunta? Ok. Está falando como médicos geralmente têm serviços técnicos excelentes, mas que faltam atitudes com conhecimento para comunicar com o paciente. Ok? Então ele falou assim que nursing, enfermagem pode contribuir em 2 níveis, para melhorar isso, especialmente comunicação, que é essencial para garantir que saúde, um tratamento mais eficaz, e uma melhor avaliação de resultados.
So health services are optimized if 3 conditions are met. 3 conditions. First, you have to respect ethical values, first one. Second, the economy has to be related to the patient. Okay? Economy has to be related to the patient, and nursing has to be evidence-based. So what does that mean? Nursing has to be evidence-based. This means that the actions which are taken by nurses should be based on data which demonstrate that a good outcome will result.
Ok, enfermagem baseado em evidências, data, dados. Ok, tá claro isso? Yeah.
So, and I will shorten the lecture a little bit and will show you one important experiment. Next one, go to the next one. So the first aspect was the 4 ethical values. Do nurses have a discipline like ethics? Yes, nurses have ethics. So you are aware of the 4 principles of ethics. This means autonomy in the same, autonomia. Beneficience, that means you should do something good. You should add value. Yeah? Non-maleficence means you should not harm the patient. Okay? And the first one, justice. Entitle others. So include the patient.
Autonomia, ok, preferências do paciente. Beneficence, fazer bem ao paciente. Non-maleficence, que é não fazer algo ruim que pode prejudicar, ok? E finalmente, justice, justiça, ok? Dar acesso, incluir pacientes, ok? Não excluir pacientes.
So the next task is the economy has to be related to the patient. So I have to explain the difference between economization and commercialization. Economization means to apply the principles of an economic analysis. And I told you the principle of an economic analysis with the pineapple for 3 reais and the better one for 4 reais. So this is an economic principle. And we should apply these principles of economy to health care and to nursing. This is completely different from commercialization. Commercialization means to make profit, to make money out of healthcare. And this is something terrible which is increasing, for instance, in the United States. It's increasing in Germany. So there is another important difference. This is the difference between clinical economics and health economy. Health economy is something which is done by economists. Everybody knows an economist. They are in the school of economy. And clinical economists, these are nurses or doctors or physiotherapists. These are people who take care of patients. But they should also know about the economic analysis. Can I have the next slide? Próxima. Thank you. Obrigado. So, this is a table. Don't be afraid. I will not go to the whole table. I just will show you. There are many different aspects. Let me just go to the primary outcome. So the primary outcome in health economy is monetary costs. So the economists look after the money. Primary outcomes in clinical economics is quantity and quality of life.
Outcomes. Ok. Resultados. Ok. Resultados.
So, go to the next one. Go to the next one. So, economy is patient-related when you consider the patient versus societal perspective. So what does this mean? A medical doctor is concerned that the patient is doing well. An economist has a completely different perspective. He is not interested in patients, in individual patients. He is interested in the society. So what is more important? The individual patient's perspective or the societal perspective?
É a pergunta, perspectiva, assim, da visão do paciente ou da sociedade. Okay, qual que é mais importante? You answer that question? Yeah.
And you know, there is no answer because it depends on your perspective. The medical doctor is looking for individual patients, or nurses are looking for individual patients. Economists have a different perspective. They are looking at society at all. And this is sometimes a problema. So the next one. So nursing is evidence-based. There are 5 forms of bias. Do you know what a bias is? Not. A bias is a systematic mistake. You know, a random mistake is when you have a gun and you shoot to hit this point up there. And sometimes you go a little bit higher, sometimes you go a bit lower, sometimes you go to the left, sometimes you go to the right. This is a random error. A random error.
Ok, entender bias como erro aleatório. Ok, nesse contexto. Ok, sistemático. Ok.
So, I give you an example. I give you an example for a systematic error. You have a gun, but the gun is like this. You know, the gun is like this. Torto. You know, so you try to hit this point, you know, and you always go this way. You always go this way. So you do a systematic error. And this is very difficult to detect in medicine. And I will show you examples of systematic error. So you have to know bias. Validity of clinical trials, of meta-analysis, HTA reports. This means if the content of a scientific paper is really true.
Ok, validity, a veracidade de conteúdo. Ok, a veracidade de ok. E HTA? Todo mundo sabe que é
Health Technology Assessment.
Ok, HTA, análise de saúde tecnológica, tecnologia de saúde.
Okay. So, and then it's very important, I will show you that what is your suggestion? Are we in medicine doing too much or are we doing too little? What do you think?
A pergunta, estamos fazendo demais na saúde ou a gente não está fazendo o suficiente? Fazendo pouco? O que vocês acham? Too little?
Do you think we are doing too little? Wrong. You're wrong. Our problem is that we are doing too much. We are doing too much, and I will tell you in a second why we are doing too much. So these are several forms of bias, and I will not go into details, but I can tell you I will come back to Niteroi next year. And I see some faces. They know already what these types of bias are. So this needs an extra lecture to explain what these types of bias are. But you know, these are systematic mistakes. Systematics. Torto. When you have a gun which is torto. This is a systematic error. Next one. So, I want to show you how to confirm validity of a clinical trial. And I give you some examples. So this is about breast cancer screening. You are all aware of breast cancer screening. Breast cancer screening is very important for women. And this paper here, it's described by Blyer and Welch. It was in December last year, and they summarized the results of breast cancer screening from 1976 up to 2011.
Ok, pessoal, é sobre mamografia, ok, breast cancer screening.
So, and they could show that 76 to 1976 until 1984, there was no breast cancer screening. You know, it started in 95 or so. And then it was increasing, and it reached a plateau about in 1998.
Ok, como mamografia só começou em 1985, subiu, estabilizou aqui em cima, ok, 2004.
So, and as a result of the introduction of mammography, the early stage breast cancer. Do you understand early stage breast cancer? So very small breast cancer. The rate of early stage breast cancer increased from 120 per 100,000 women up to 240. So it was doubled in the period between 1980 and, let's say, 2005. The detected cases of early breast cancer. So what would you expect when you detect early breast cancer and you do some surgery in these breast cancer cases? Then you would expect that the number of late stage breast cancer will go down.
Bom, aqui, identificação de câncer, seios, fase inicial, ok? Essa detecção dobrou. Então ele perguntou o que você esperaria que a detecção de late stage, fase, ok? Mais tarde, aumentaria também, ou diminuir, ficaria menor, right? Would go down, right?
It should go down.
Deveria diminuir, ok? Por causa dessa detecção na fase inicial.
But, you know, you see, the observation was that late stage breast cancer did not go down. So this curve here, the yellow curve, is exactly the same like this curve here. You know, the yellow one. It's exactly the same. And it tells you that late stage breast cancer has two subgroups. A regional disease, that means a recurrent disease in the breast or in axillary lymph nodes.
Sim?
Fazer comparação, o levantamento dos dados do estudo. Ele está fazendo que a gente baseada em evidência. Faz o levantamento dos dados do estudo e ele está dizendo, nesse estudo, no levantamento desse estudo, as pesquisas mostraram que levantando, se ele fizesse uma mamografia precoce, ele teria identificado mais casos. E que ele não teria caído no número de casos tardios. Seria que só que ele prova ao contrário, está dizendo que não. Que ele, mesmo levantando os casos novos, ainda mantém uma constância de casos tardios. Né? Então ele está questionando isso. Então ele está fazendo essa proporção de casos. Tá?
O questionamento é se a mamografia mudou o prognóstico do paciente. Essa é a ideia. Eu estou detectando mais cedo, mas as pessoas continuam adoecendo embora tudo isso não seja precoce.
So I understood perfectly what she said. You know, yeah, I will show you. You know, she said that late stage disease, this is the dangerous type of breast cancer. You agree? Late stage, this distant disease, where you have brain metastasis, bone metastasis, lung metastasis, liver metastasis. So this means distant disease, late stage. And the problem is, what we did not know before, what was really new to all of us, that distant disease, late stage, was absolutely the same in 1976 and in 2008. So now we can discuss, what does this mean concerning mammography screening? Should we send people further on to get screening, or should we discuss that the screening may not be as effective as we expected it to be?
Quando me faziam os exames, alguns como na detecção de casos, alguns eram os tumores principais, outros eram as metástases, invasão casos, e aí era mais. E quando as pessoas, quando faziam as análises, entendiam como sendo tudo igual. E aí por isso que dava as linhas de corte diferentes, né? Então câncer tardio, regionais, então ele conseguia fazer, que é a segunda tabela, as análises diferentes. Então por isso que ele existia das análises. Ele achava que tudo era na mamografia, ele identificava todos os tipos de câncer. Então eles podem fazer análise diferenciada para ver o que é o tumor principal ou era os metástases ou os tumores localizados. E aí na matemática, na aula de estatística, os números eram todos iguais. Aí, aula de estatística.
You see how important statistics is. When you don't understand statistics, you will make horrible mistakes. You will make horrible mistakes. So please think about this. Discuss this result with your statistical professor before you make decisions. Imagine, now I have to tell you a terrible story. Imagine you go to downtown Niterói and you would tell the women in Niterói that breast cancer screening does not work. What would you expect will happen?
Ele está perguntando o que se antes ele falou para discutir qualquer resultado com o professor de estatística e depois ele falou que se nós sairmos aqui e formos falar com as mulheres na rua que a mamografia não funciona, o que vai acontecer?
They will show you.
Do you understand what happens? Because mammography gives you the feeling of safety. You know, you feel safe when you have mammography. And we, nurses and doctors, we were teaching to the public in the last 20 years that mammography is muito importante. So now we cannot go out and tell them it doesn't work. It's impossibile. So we have to think about, and we have to develop strategies how to handle this new problem. But this example, I want to show to you this example just to tell you how important outcomes are, how important statistics is. So without statistics, without outcomes, you will have a problem. Next one. This is another story about statistics. I will make it very short. But these are two very famous people in statistics. This man, both come from London in UK. And he was an evolutionary biologist. And he was thinking about agricultural fields. You know, how to get the best result when using different kinds of nutrition for these plants and so on. So, and he was the inventor of randomization. Do you know what randomization is?
Ele está falando sobre randomização, né? Uma das formas de se prevenir o erro sistemático, o viés, o que ele está chamando de bias, nos slides. No português nós chamamos de erro ou vício. Esse erro ou vício ele pode ser aleatório ou sistemático. O erro aleatório é aquele que você dado ao acaso. Exemplo, se nós fizéssemos um sorteio aqui de 10 pessoas, pode ser que por ordem do acaso, essas 10 pessoas que fossem sorteadas, e eu estou analisando a variável peso, por exemplo, ou idade, pode ser que ao acaso, as 10 pessoas que fossem sorteadas fossem as 10 mais obesas, as 10 mais pesadas. Então, isso é um erro aleatório, é um erro que se dá ao acaso. Diferente de um erro sistemático, que ele deu o exemplo da arma, né? Você dá um tiro, a arma ela está torta e você não acerta o alvo. Então, isso é um erro constante, né? Então, trazendo para a nossa área, por exemplo, eu estou fazendo um grande estudo que leva em conta o controle de pressão arterial. E o aparelho de pressão não está calibrado. Então, isso passa a ser um erro sistemático. Todas as medidas vão sair erradas por conta da falta de calibração do aparelho. Então, aqui ele está falando sobre a randomização, que seria uma forma de se evitar esse erro aleatório. Quase randomização, no português isso é traduzido como randomização ou encaminhamento aleatório para grupo. Então, seria um sorteio, em última análise, como forma de prevenção de um erro sistemático.
So, and then something terrible happened. Because these two men, they met, they came together. And Sir Bradford Hill, he was an English epidemiologist. And he was taking care of patients. And he was thinking, oh, this idea of randomization may be an excellent method for patients. But he made a terrible mistake. The next one. Fisher and Bradford Hill made essential contributions to medical science, but did not discuss the effects of human preferences.
Bem, gente, ele está explicando aqui que esses dois pesquisadores, eles contribuíram e muito para a ciência da medicina. Só que eles não discutiram a preferência do paciente quanto a isso, quanto à randomização. Tá? Então, ele mostra que os dois andaram juntos, um com a parte mais médica e o outro com o estudo randomizado, e aí, só que eles tiveram um erro que eles não discutiram a preferência do ser humano.
Imagine somebody has cancer here of the knee, and the doctor would say, "Oh, we include you in the randomized trial, where the computer will decide whether we do surgery, amputation of the leg, or we do radiotherapy."
Ele está falando do estudo, que ou faz a amputação do membro, ou faz um estudo de radioterapia. Tá? Então, são esses dois tipos de paciente.
So you can imagine, many patients will not agree. They will tell, "Oh, I do not want to get surgery. I want to get radiotherapy." So these patients have a preference for radiotherapy.
Alguns pacientes tinham a preferência de fazer a radioterapia ao invés da amputação. Isso que ele está falando.
Yeah. So, and this happens very often. Next one. So I show you the example of a randomized study. Imagine 80% of the patients prefer treatment A, and 20% of the patients prefer treatment B. Then you randomize them in two groups, and in both groups, 80 will prefer A, 20 will prefer B. 80 will prefer A, 20 will prefer B. This group will receive treatment A, and this group will receive treatment B. Do you see the problem? The problem is that in this group, 80% get the preferred treatment, and in this group, only 20% get the preferred treatment. Can you explain it?
Bem, levando para o exemplo que ele falou da radioterapia e da amputação do membro, nós temos que 80% preferem a amputação e 20% preferem a radioterapia. Só que quando dividiu em dois grupos, os 80% que preferiam a amputação tiveram a amputação. E, sendo que os 80% que queriam a amputação tiveram a radioterapia. Só 20% que foi o tratamento que eles queriam. Certo? Então, mostrando o problema do estudo, que 80% do tratamento A teve o tratamento que quis e 20% do outro lado teve o tratamento que quis também.
So, if the preference is important for outcome, if the preference is important for outcome, you have a problem here, because here 80% will show a better outcome, and here only 20% will show a better outcome.
Se a escolha do paciente é importante para o resultado, como ali naquele estudo, somente 20% estava tendo o tratamento que queria e 80% do outro lado. Então, só tinham 20% que escolheu aquele tratamento.
So, this is why outcomes are so important. Next one. And this is a new design. This is a so-called pragmatic controlled trial, which is a supplement to a traditional randomized controlled trial, but I will not explain it to you right now. What I will do, go to the next one, I will show you that we will have the problem of doing too much. The problem of doing too much is much bigger than the problem of doing too little. Imagine you have this benefit window. That means you can improve patients by a treatment who have about this risk of survival or this chance of survival, and this proportion of patients here, they will survive even without health care. They do not need treatment. This group up here, they will die even with treatment, and only the very small group in between, they will benefit from your treatment.
Se eu te falar alguma coisa, aí ele faz a divisão dos pacientes que têm o risco de a sobrevida maior e a sobrevida menor ao tratamento. Ou seja, ali que ele está falando que o risco de se fazer muito, aqueles pacientes que mesmo com tratamento, eles vão falecer, e somente essa pequena escala aqui, o tratamento vai ser eficaz. Então, só aquela pequena janela que você vai ter uma eficácia do tratamento.
So, when you treat all patients, you can conclude that you will do too much, because these patients will not benefit from treatment, neither will these patients benefit from treatment. So the important thing is we have to identify this small group of patients who benefits from treatment.
Aí volta naquele início que ele falou que nós estamos fazendo muito pelo paciente ao invés de pouco, quando ele perguntou a gente. Por quê? Nós temos que saber diferenciar qual o paciente que precisa do tratamento daquele que não vai precisar daquele tipo de tratamento. Essa é a divisão em grupo que ele fala. Por isso que ele fala que nós estamos fazendo muito pelos pacientes.
So now I will come to an end, and I will show you what nurses can do to identify better outcomes. Go further on. So, I want to propose to you a project. I'm very much interested to get your opinion on this project.
Ele falou que vai mostrar para a gente onde é que a enfermagem pode atuar nessa seleção de paciente. E aí ele propõe para saber a nossa opinião com relação a esse processo, que ele quer fazer um projeto com a nossa opinião.
So the project is called Perceived Safety, a Critical Incident Detector. That means, do you know what perceived safety is? This is the safety which you can feel. Imagine you have two people jumping out of an airplane with a parachute. And the first person is on his first jump out of the airplane, and the second person is on his 100th jump. The probability of landing safely will be about the same, but the perception of safety will be quite different.
Nós temos duas pessoas pulando do avião com paraquedas. A primeira, ele é a primeira vez que vai pular. A segunda já fez várias vezes. Ele fala que a aterrissagem vai ser segura para os dois, mas a percepção daquele que está pulando pela primeira vez, o sentimento vai ser diferente. Então é isso que ele quer mostrar para a gente.
So, the probability of landing safely, this is real safety. Real safety. And the other one is perceived safety. This is a psychological effect. So, and psychological effects are so important in medicine. So important. So this project is about perceived safety. So some members of a medical team, doctors or nurses, can smell an emergency situation. Is this true? Do you think it's true?
Nós podemos sentir o cheiro da emergência. Está perguntando se é verdade. Se médicos e enfermeiros conseguem, pela percepção, saber se é grave ou não o caso do... Sim. Yes.
So, can smell an emerging critical incident. Other members of the team miss. We call it a sixth sense. Is it the same in Portuguese?
Sexto sentido.
So, miss this sixth sense and will recognize a critical incident only hours later. Only hours later. And may waste important hours for prevention.
Ele está falando que sobre o sexto sentido, que é a percepção do médico e do enfermeiro, que os outros membros da equipe vão demorar mais tempo para perceber do que o médico e do que o enfermeiro.
But you can translate it directly. Communication with and without the sixth sense may be difficult, especially when time is important.
Comunicação entre os membros sobre esse sexto sentido pode dificultar esse tempo que é muito importante, que é o sexto sentido. Esse projeto pode providenciar uma necessária resultado para tomada de decisão política e médica que gera valores com relação ao sexto sentido, essa percepção precoce. Isso é simples. O doctor ou o enfermeiro que está interessado a participar desse processo, eles dão o número de telefone. No caso de uma incidência crítica, ele ou ela podem, juntos, dar o número e aí esperar pela confirmação por correio de voz, por voz eletrônica. É só ligar para esse número. Eles dão um número para o paciente, com esse número ele consegue ter a percepção.
So now go to the next one. The electronic, when she calls this telephone number, there will be an electronic voice. And this electronic voice will just record the telephone number and the name of the calling person, and as well as the telephone number and the time of calling. And then the next working day, this office, of this study, will call the person who did the critical incident call and will request on the telephone additional information on the type of the critical incident, on the actions that were taken, and on the acute outcome within the first 24 hours after the call.
Ele está explicando como vai ocorrer o processo. A pessoa vai ligar, vai falar com a voz eletrônica, aquele telefone vai ficar arquivado, assim como o número da pessoa. Depois eles vão retornar do estabelecimento, vão ligar para a pessoa para saber o que aconteceu, um telefone adicional e as ações,
Ok, entendendo que vai gravar o número de telefone, a pessoa que ligou e a hora da ligação, ok? No dia seguinte, se for um dia útil, ok? O escritório vai ligar para essa pessoa, ok, que fez essa chamada, e no telefone vai pedir informações adicionais do tipo do acidente, do tipo do incidente, ok? Sobre as medidas que foram tomadas, ok? E os resultados, ok? Depois dos primeiros 24 horas da chamada, ok?
So it is suggested to collect records of about 50 calls, to collect these 50 calls and to publish the results. If the results demonstrate a low incidence of false positive, so that means whenever a doctor or a nurse makes an critical incident call, it's really a critical incident call. If this happens, if we can confirm this, it will be worthwhile to continue the project with the second phase. In the second phase of the project, it should be shown that this project may save lives and a lot of money. It will save lives and money and may improve the cooperation of doctors and nurses.
Ele está explicando que nesse processo eles vão colher 50 ligações, vão publicar o resultado. Se ele conseguir provar que dessas 50 ligações, o número de incidência vai ser menor do que 25%, ele vai dar continuidade ao projeto. Vou dar a parte de...
A continuidade do projeto para a segunda fase estaria vinculado a uma baixa incidência de resultados falsos positivos. Lembrando que o falso positivo, ele é o complementar
da especificidade. Ok? Então, pensando que especificidade é a probabilidade de um resultado negativo, dado a ausência da doença, do efeito, o que seria o complementar disso? O indivíduo fazer a chamada e não ter nada a ser apurado efetivamente. Seria o trote, trazendo para a gente. Então, se o índice de trote for abaixo de 25%, um quarto, eles seguiriam para uma segunda fase.
So this is the last slide. And this last slide shows you I have 2 offices in Germany to work. This is the surgical department of our university hospital. And this one is a castle on the countryside. And I have the opportunity to have one little office in here, and I have another little office in here. And whenever you come to Germany, you just give me a call, and we may meet either in this place or in the other place. Thank you very much for your attention. Muito obrigado.
Ele falou que ele tem 2 pequenas salas em cada um, no núcleo de cirurgia e no outro no interior da Alemanha. Que se vocês precisarem dele, não precisa ir lá, que pode ligar para o telefone dele. Muito obrigado.